Bismillahirrahmanirrahim. Now moving on to the second portion, that is water soluble vitamins. We have studied about fat soluble vitamin A, D, E, K, and their diseases. Now we'll move on to the second section that is very important because it includes water soluble vitamins and everything other included on this page as well. So, first, they are B complex and then vitamin C. These are to be discussed here. There are other names for B complex and even vitamin C. Everything is asked in MCQ, so you have to jot them down and make concepts as well. Vitamin B1, B2, B3, there is no B4, B5, B6, B7, no B8. So 4 and 8 are missing, 9, 10 missing, 11 missing, and 12. Because there were some molecules here as well, but they are now not termed as vitamins, so they are out of this list. So we will discuss only these. So first, B1, also called thiamine, and thiamine pyrophosphate (TPP) is important cofactor for it. Important enzyme is dehydrogenase enzyme. We'll learn about it. And important dehydrogenase enzyme is important in glucose metabolism. Then B2, riboflavin, flavin, adenine dinucleotide, flavin, mononucleotide. These are cofactor for riboflavin or vitamin B2. And then B3 or niacin, uh, N for niacin, N for NAD, nicotinamine adenine dinucleotide. This is cofactor for B3. So FAD and NAD, B2 and B3 are important in redox reactions. We know that reduction hydrogen present with FAD and NAD, they will lead to as a reducing agent. So reduction reaction, redox reaction. There is a concept for everything if we learn about vitamins as well. Then B5, pantothenic acid, P for penta and P for 5, B5, and it is acyl transfer vitamin, and in CoA, acyl CoA. It's not acetyl, it is acyl CoA transfer. So one first vitamin which is for transferring, other will be discussed ahead. B6 or pyridoxine, it is important for transamination reactions related to ALT and AST in the liver. So B6 pyridoxine, we know that in TB, isoniazid use can lead to pyridoxine deficiency, and that is also asked in MCQ. And transamination reaction is another MCQ related to B6. I will discuss in detail as well. And then B7 is biotin. Biotin for carboxylation reaction. We read about carboxylation reaction of gamma carboxylation in vitamin K, but here it is B7 carboxylation. Add one carbon, specifically asked, and no gamma carboxylation is asked. And also oxidation of fatty acid is asked in related to B7. And if fatty acids are mentioned with B7, that we know that vitamins and requirements for them for carbohydrate is B1. B1 we discuss dehydrogenase is related to glucose, and we will discuss. And lipid and carb and fats is B7. So here B7 is oxidation of fatty acids related to fats. And protein is B12 riboflavin for protein. This is also important, so I have jotted them down separately. And vitamin B9 and B12, I have made them green because they are two very closely linked. B9 is a folate, it is present in green vegetables, and B12 is opposite to it, it is cobalamin, it is present in meat and other animal products. Both are used in methylation reaction, one carbon transfer. If one carbon is asked at carboxylation B7, and one carbon transfer methylation is asked, preferably it is B9 and also B12. So we prefer B9 over B12 here because B9 deficiencies are common. And if megaloblastic anemia is asked, even then we prefer B9 more than B12 unless neurological symptoms are there. And then we prefer B12 because they are specific to B12 as well. Vitamin C after the B complex, it is second name is ascorbic acid. It is used in the hydroxylation of proline and lysine in collagen synthesis. So collagen synthesis defect will be there. And now moving on to first vitamin, that is B1 or thiamine. We know that it is TPP, thiamine pyrophosphate, as a cofactor. Another MCQ asked is it is present in wheat. So wheat is related to carbs, and carbs are related to B1. They are taken, should be taken with B1. It is present for very dehydrogenase enzymes and branch chain ketoacid dehydrogenase, alpha ketoglutarate dehydrogenase, pyruvate dehydrogenase, transketolase. So first three are dehydrogenase enzymes, branch chain and alpha keto. TCA cycle, they are used in TCA cycle. We know that is the breakdown of pyruvate into further chemicals and release of energy from glucose molecule that has produced pyruvate. So carbs or glucose are related to dehydrogenase and B1 or thiamine. Everything will be related to it. Carbs, B1, thiamine, and dehydrogenase enzymes. Pyruvate dehydrogenase is for the links the glycolysis and TCA cycle. That is a linker enzyme. And transketolase is important, HMB shunt enzyme, and diagnosis of B1 deficiency is made by increased RBC's transketolase activity following B1 administration. So this transketolase is important in diagnosis, and other are important in diseases. We'll see. In impaired glucose breakdown, ATP will be depleted. So if we for ATP will be depleted, so glucose is used in brain and heart, mostly in brain, because that specifically uses glucose or ketone bodies. And so in case of vitamin B1 deficiency, there won't be these dehydrogenases, and glucose breakdown like in TCA, linking glycolysis and TCA will be abnormal. Impaired glucose breakdown, that's why I said ATP will be depleted specifically in brain. So brain related symptom will be there, like Wernicke encephalopathy, ophthalmoplegia, that is asked, Wernicke Korsakoff syndrome is also asked, and beriberi, dry beriberi is also neuron related polyneuropathy, but wet beriberi is cardiac related. So we know that the second most important organ is heart for glucose metabolism. So brain and heart, dehydrogenase, carbs, everything is linked. You listen one word, you know it is the B1 automatically. And we know that in alcoholic and malnourished patient, vitamin B1 or thiamine is given before dextrose to decrease risk of precipitating Wernicke encephalopathy. In alcoholic, there is alcohol is going in body and used in place of glucose, and if the enzyme B1 will be used to counter the alcohol, and it will be deficient. So if we give the dextrose to the same patient before administering deficient B1, the dextrose will also use B1 for own metabolism, and that leads to severe B1 deficiency and Wernicke encephalopathy in the brain. That is asked. We should know the mechanism as well, that alcohol may precipitate B1 deficiency, and other is carb consumption increases demand for B1. So should be taken with carb diet, because B1 metabolizes carbs, specifically glucose, and found in the wheat. And then Wernicke encephalopathy, other symptoms are only ophthalmoplegia is very important. It is a triad of ophthalmoplegia, confusion, and ataxia. Korsakoff syndrome is a menistic disorder. The patient forgets a lot, and chronic alcohol consumption, confabulation. He confabulates the truth by himself, telling the lie, try to cover up the things. So alcoholics do so. Korsakoff, suffering from Korsakoff syndrome, and both symptoms are together if there is ophthalmoplegia and this triad, and as well as confabulation related and memory related issues, which is Wernicke Korsakoff syndrome. So Wernicke encephalopathy, Korsakoff syndrome, Wernicke-Korsakoff syndrome, these are all related to B1, and we know why B1, because brain, B1 and glucose are related, glucose metabolism or carb metabolism. Then very important is dry and wet beriberi. Beriberi, dry beriberi is related to neuropathy, polyneuropathy, and especially in the brain there are neurofibrillary tangles that is asked. You should add on it here. Neurofibrillary tangles are present. These are also present in Alzheimer disease. And wet beriberi related to cardiac issues. High cardiac output failure, dilated cardiomyopathy will be there. And we know why it's there, because the second important organ for carbs is heart. So dry beriberi 1 disease, brain related, wet beriberi 1 disease, brain related dry beriberi, brain and neuron related Wernicke, Korsakoff, and Wernicke's separately. Transketolase enzyme is important for in RBC for measuring for diagnosis of B1 deficiency. So carbs and B1 or thiamine is very much linked. Moving on to B2, B2 related to protein, we know that carbs and proteins. Riboflavin is the second name, and B2 and B3 are redox related vitamins. We know that FAD and NAD, they have hydro H with them, that is reducing agent, so they are used for redox reactions. Riboflavin for B2 and niacin for B3, and protein for B2 as well. So should protein should be taken with riboflavin. Redox reaction is another important thing. Deficiency is cheilosis, that's inflammation of the lips, and scaling and fissure the corners of mouth called angular stomatitis. Cheilosis and angular stomatitis, B2 deficiency, the only thing mostly asked. Other is B2 should be taken with protein diet, and cofactor fat, FMN. And I have jotted down here as well carbs, B1 thiamine, we know glucose and Wernicke issues, B2 or riboflavin protein, and lipid for B7 or biotin, we know that oxidation of fatty acid, biotin is important. For B3 niacin, it is N for niacin, N for NAD, and NADP. Again redox reaction, because hydrogen is used in reduction reactions, and derived from tryptophan is in another MCQ. B3 or niacin is derived from tryptophan amino acid, and it lowers the VLDL level, that is bad cholesterol. So niacin is used in the treatment of hyperlipidemias. Here we need to differentiate that this is the treatment of hyperlipidemias, and B7 or biotin is related to lipid metabolism, that is normal metabolism. So lipid should be taken with B7, and B3 lowers level of one form of cholesterol, that is VLDL. And then important thing, B3, there are three symptoms, 3Ds for B3, that is called pellagra, diarrhea, dermatitis, and dementia. And dermatitis is usually C3 and C4 level on the neck. We can see in this patient V shape, castle necklace appearance or broad collar rash, and dermatomal appearance, that is very famous for pellagra and niacin deficiency. Heart nerve disease can also be asked, but mostly it is the pellagra that is asked. Then moving on to B5, we skip the B4, it is not there. B5 or pantothenic acid, penta for 5, we know. Component of coenzyme CoA, we know that acyl CoA transfer, vitamin important in acyl CoA transfer, and its other name is pantothenic acid. Other MCQ asked about it is milk is notoriously deficient in pantothenic acid. So these are important MCQ asked. Second name, its function as coenzyme, and milk is deficient. Then B6, it is pyridoxine. We know that it is important for transamination reaction, especially ALT and AST related. and synthesis of certain neurotransmitter as well, but that is important in its disease, that is peripheral neuropathy. Just like lead causes peripheral neuropathy, or B1 in cases of uh, dry beriberi peripheral neuropathy. But if B6 is given, it is preferred peripheral neuropathy, especially the peripheral neuropathy is due to isoniazid use, and that is treatable with B6 or pyridoxine supplement, especially in TB treated patient or during treatment. And then sideroblastic anemia, specifically B6 deficiency. B7 biotin, again carboxylation enzyme, add one carbon group. It should be compared with vitamin K, that is fat soluble vitamin, that leads to gamma carboxylation. Here it add carbon in case of pyruvate carboxylase, in case of acetyl CoA carboxylase, proponyl CoA. So every these are fatty acid chains are formed by adding these carbon, and oxidation of fatty acids related vitamin is B7. So lipid diet should be taken along too, because its demand is increased along with B7. B7 should be taken if lipid diet is taken. Otherwise, B7 deficiency will be there. And carb diet, if B1 should be taken with carb diet, and B2 with proteins. And the deficiency is related to egg ingestion, excessive eggs, because eggs have avidin in it that binds with biotin and won't let it absorb. So B7 related to eggs, oxidation of fatty acids, and carboxylation enzyme. Add one carbon group, and carboxylation, gamma carboxylation is vitamin K, and adding of methyl group is B9 and B12. We'll discuss it here. It's also one carbon transfer, but methylation reaction. Here it is carboxylation reaction. B9 and B12 should be discussed together because both are related to one mechanism that is discussed here in B12, that is methionine. Adenosine is formed in the end, homocysteine methionine in metabolism, and tetrahydrofolate is folic acid that transfers the CH3, and B12 is acting as cofactor here. So B9 as tetrahydrofolate and B12 are at the same juncture, but B12 is related to methionine more. It is close to methionine metabolism, and homocysteine is increased in case of B12 deficiency, but it is not increased in case of B9 deficiency. We will discuss it. Uh, B9 is folate. It is present in leafy vegetable. Uh, Otherwise, B12 is present in animal products. Opposite to it, a coenzyme for one carbon transfer or methylation reaction. It is preferred over B12 coenzyme. Both are coenzyme or other is B12 is specifically cofactor, if you use the exact word, for methionine synthase methylation reaction, and B9 is coenzyme for one carbon transfer methylation reaction. Again, same reaction, but one carbon transfer is more close to B9 because it is CH3 group, and that CH3 group further transferred with alpha B12, as it is acting as a cofactor in methylation reaction of methionine synthesis. Word methionine synthase is used, and B12. If just one carbon transfer, then it's B9. And green leafy vegetable B9, and almond products B12. And the next is B9 is absorbed in jejunum, and B12 will be absorbed in ileum. Storage duration B9 3 to 4 months, and B12 3 to 4 years. It is important because of case scenarios given in which there is just a few months of issue, then it is more of B9 deficiency than B12, and if there is megaloblastic anemia or shared symptom for both. So DNA synthesis is impaired. Here we see that adenine is produced, and the tetrahydrofolate or folic acid and B12 cobalamin both helps in adenine synthesis and DNA synthesis ultimately. So if there is no DNA synthesis, especially in RBCs that are required in the body, the DNA, if not synthesized, leads to abnormal nucleus formations, and that is called hypersegmented polymorph nuclear cells, or neutrophils are polymorphs. There are many segments, more than five, I think, in high polymorphs. And macrocytic means more than 100, uh, if MCV is more than 100. Megaloblastic anemia means hypersegmented nucleus is there. Mild difference, but it is important to differentiate macrocytic and megaloblastic. And B9, there are no neurological symptoms. We know that anemia without neurological symptom. And B12, we have hypersegmented polymorph neutrophils, megaloblastic anemia, and with neurological signs. We'll edit this without in the page. It is with the neurological sign cobalamin. We know that it is important. It is the subacute combined degeneration, usually of dorsal column, so leads to symptoms of dorsal column. Supplemental folic acid is given in maternal pregnant ladies, because if not given, it leads to risk of neural tube defects, specifically defects spina bifida and anencephaly is asked. Neural tube defects instead of neural tube defects, they may say B9 deficiency leads to anencephaly. And homocysteine is raised, and normal methyl malonic acid. Um, we'll discuss in the reaction in B9 and B12, both homocysteine is raised. It was wrongly said that homocysteine is not raised in tetrahydrofolate deficiency. We know that it is the same reaction B12 and B9 are dealing with. So any deficiency will lead to the raise in the homocysteine level. But B12 is also used in another reaction separately. If here it is deficient, a methyl mineral CoA mutase is not functional, and methyl malonic acid levels are raised. So both methyl malonic acid and homocysteine in B12 deficiency, and only homocysteine level raised in B9 deficiency. So increase homocysteine, normal methyl malonic acid B9, increase homocysteine, and increase methyl malonic acid B12. And then of course pregnancy folic acid supplement should be given. And in B12 we'll discuss about the intrinsic factor that is important for absorption of B12 secreted from gastric parietal cell in the stomach, and gastrectomy. So gastrectomy leads to B12 deficiencies as well. And terminal ileal dissection, because it is absorbed in the terminal ileum, unlike B9 that is absorbed in jejunum. So B12, it is called cobalamin. Second name, a spool is for more years, that instead of 3-4 months like B9, it is for 3-4 years. It is one of the vitamins who is water soluble, and still it has so much storage duration. And Asnedius asked about diphyllobothrium latum, that is fish tapeworm that is present in fishermen, that uh, intestinal parasite that causes a deficiency of B12, specifically diphyllobothrium latum. And then important is the lack of intrinsic factor, that is specifically if autoimmune destruction of intrinsic factor or parietal cell is there. So anti-intrinsic factor antibodies are diagnostic of pernicious anemia. Specifically pernicious anemia, there is auto antibodies against intrinsic factor and against parietal cell as well, because parietal cell secretes intrinsic factor. Then gastric bypass surgeries, in gastric bypass, gastric release of intrinsic factor won't be there, so it also leads to the same as pernicious anemia is there. Then terminal ileum is the absorption surface, so intrinsic factor and B12 are absorbed in the terminal ileum. Surgical resection of terminal ileum is there, it will also lead to B12 deficiency. So case scenario can be asked for auto antibodies are given, or gastric surgery given, or terminal ileal resection is given. Then again MCV more than 100, macrocytic anemia just like B9, folic acid, megaloblastic just like B9 with hypersegmented polymorph neutrophils. And add-on symptoms are with neurological symptom paresthesia or sensory symptom subacute combined degeneration of dorsal column is important, that leads to balancing issues. And this is asked balance issues and vibration sensation issues. We know that these symptoms also happen in vitamin E deficiency, but without megaloblastosis. And folate supplementation, if given before B12, will aggravate signs of B12 deficiency. Why? Because this reaction, if folate is given more, leads to more reaction, and B12 only present will automatically be deficient in a few days. So it is advised to give folate supplementation before B12 supplementation. Folate, and also folate supplementation can mask the hematological symptoms of B12, because hematological symptoms are due to folate as well as B12. So if folate is given more, it will cover up the B12 deficiency, but not the neurological symptom. They are specific to B12. So if neurological symptom is given with megaloblastosis, it is automatically B12 deficiency. Needs intrinsic factor for secreted by gastric parietal cell. We know that anti-intrinsic factor antibodies are produced. Then antioxidants, we can say many vitamins are antioxidant. Vitamin C is a very important, ascorbic acid, but the general orientation of it is get CA. You can remember glutathione, that is not a vitamin but a molecule. Then vitamin E, then transferrin, then vitamin C, and then vitamin E. If only most potent or one is asked, then we prefer in this sequence. Glutathione is preferred. If vitamins are asked, then vitamin E is preferred. If transferrin is given, and vitamin C and E are given, transferrin is preferred. If antioxidant are asked, if only vitamin C or vitamin E are given, they are tick as right. So vitamin C is ascorbic acid, is B, after B complex. It is also water soluble, and it is an antioxidant. We know the list. It is after vitamin A, it is most potent, and facilitate iron absorption. Why? Because it converted into Fe uh, 2 plus form from 3 form. Fe2 is absorbed because it is divalent metal transporter in the GIT, DMTs. So divalent ions would be absorbed. And also, if calcium is there, that is also divalent, that may compete with this iron as well as DMTs. So two DMTs at a time may also hamper each other absorption, but that's not to be discussed here. Just DMTs are related to Fe2, and Fe2 is produced by is a production is increased by ascorbic acid. So vitamin C increases iron absorption, and tannates present in tea, especially tea and tannates, decreases iron absorption. And vitamin C, citrus fruits, C for citrus fruits and vegetables. And S for scurvy, vitamin C deficiency leads to scurvy, because vitamin C is important in hydroxylation of proline and lysine in collagen synthesis. So if collagen synthesis in skin is not good, it will lead to collagen synthesis defect. It is not decrease, it is the defect, because one reaction is not occurring, and leads to swollen gums, easy bruisability, petechia. These are asked. It is especially related to scurvy, and sometimes even the bleeding, especially hemopericardium inside the heart cavity or pericardium, the outer covering. And then poor wound healing, also related to zinc and vitamin C. And these are water soluble vitamins, and this is how we prepare them. Then moving back to the first page, we will summarize things, that B1, B2, B3, B5, 6, 7, 9, 12, their names and their cofactors and their enzymes and their roles, they are very important. And now vitamins and nervous system, we discussed. B1 thiamine deficiency, ophthalmoplegia related to Wernicke. B6 deficiency, peripheral neuropathy, isoniazid related, TB treatment related. B9 folic acid, neurotube defect and encephaly important, again CNS disorder. B12 Cobalamin subacute combined degeneration, dorsal-column-medial meniscal system defects. Vitamin E also dorsal-column-medial meniscal defects but without megaloblastosis. Then vitamins, minerals, and skin related issues. Vitamin A deficiency, we know it is not, in fact, deficiency, it is the excess that leads to scaly dermatitis. And then B3 or niacin deficiency, pellagra, skin related dermatitis, broad collar rash, and castle necklace on the neck. Vitamin C deficiency, petechia, bruises, delayed wound healings. We just discussed uh, hydroxylation process is hampered, defective collagen is formed, and these are skin disorders only discussed here. Zinc deficiency, acrodermatitis enteropathica, protein energy malnutrition, especially kwashiorkor dyspigmentation is there. And then vitamins and sources, green vegetables and fruits as well. Overall source of vitamins: B1 thiamine is in the wheat, B9 in the leafy vegetables, B12 cobalamin in the animal products, vitamin C ascorbic acid citrus fruit, D3 or cod liver oil, cod fish liver oil. Absorption: iron is from duodenum, B9 jejunum, and B12 with intrinsic factor in the ileum. And B12 is transported in blood in bound with transcobalamin 2. That is another MCQ asked. And lead maximum absorption is by GIT, that is 10%, 90% is lost. B9, B12, vitamin E related symptoms. B12 has megaloblastic anemia neurological symptom. B9 only megaloblastic anemia, no neurological symptoms. And vitamin E neurological symptoms and no megaloblastic anemia, rather hemolytic anemia. So this is the overall orientation of vitamins. Hope it will help. Thanks.